A very good evening, everyone. It again gives me immense pleasure to welcome you all for our diabetes bites. I think अगर आज मुझे किसी ने पूछा कि किस दो बीमारी से हम लड़ रहे हैं दुनिया भर में, ऑफ कोर्स कोविड को छोड़कर, तो आई थिंक अगर नॉन कम्युनिकेबल डिजीज के बारे में अगर हम बात करेंगे तो वो होगा डायबिटीज एंड थायराइड। ये आज इतना कॉमन हो चुका है, जैसे अभी हम देख रहे हैं ओमाइक्रॉन की थर्ड वेव, हर घर में एक पेशेंट है। सिमिलरली हर घर में या तो एक डायबिटिक पेशेंट है या तो एक थायराइड पेशेंट है। तो हम ये जो एक ट्विन एपिडेमिक है, इससे क्या क्या हमें करना चाहिए, इससे हमें बचने के लिए क्या करना चाहिए, इसे और डेप्थ में जानने के लिए आज हमारे साथ हमारे दो एक्सपर्ट्स हैं। Let me welcome our first expert, Dr. Krishna Seshadri, senior consultant endocrinologist. Very good evening, sir. I think his passion is in thyroid disorders, and he's a very well-known figure in Chennai. Our second expert is Dr. A. Unnikrishnan, sir. Very welcome and good evening to you, sir. He's again, I would say, a researcher, a clinician, academician, and an entrepreneur as well. So today, both of them are going to speak on the, I would say, most important, the dual epidemic of thyroid and diabetes. So without wasting much time, over to you guys.
Well, shall we start, Dr. Purvi?
Please go ahead.
Yes, please. We can't wait to hear the conversation.
So I've been thinking about the thyroid, which is, as everybody knows, it's a little butterfly-shaped gland in the neck. And Dr. Seshadri, what do you think about the thyroid, imagining it as an endocrine organ, purely from an endocrine perspective? We know it causes nodules, it can fail, it can work harder. But what about it as an endocrine, gland? And just to introduce endocrinology to the viewers.
It's very interesting because the thyroid captures the imagination of so many people over time. I'll start off with something that my teacher, Dr. Chuck Cannon, used to say that the symptoms of thyroid disease are the symptoms of life, and therein lies a story, right? And we should also thank Sri Aurobindo for putting the endocrine glands into their perspective. Very interestingly, the thyroid is right in front of the Vishuddhi Chakra that the yogis speak about. So many people attribute many of the characteristics of the thyroid to those. That is not, I mean, while that can be debated and questioned, but what is interesting is the function of a hormone is to communicate. Unlike us, where we discovered wired communication before cellular communication, nature actually discovered cellular communication before wired communication. That hormones predate even the nervous system. We were small microorganisms in that big soup that gave birth to all of us. And when cells started organizing themselves, they had to send messages from one cell to another. And those messages were hormones. And one of the most primitive and earliest form of hormones is what the thyroid is. It's a very simple amino acid structure. It is not something as complex as insulin or any of the others. It is one of the most simple, probably one of the earliest messengers that we have that communicated health, that communicated actions, that communicated reproduction, that communicated so many things that we now take for granted. And therein comes the function of the thyroid as an endocrine gland. As we became more sophisticated and specialized, nature decided, look, I need somebody who will take care of this on its own. And therefore, it located it right in the neck. And it provided another organ to control it, which is the pituitary. And then these hormones started influencing how every cell behaves. Every cell behaves. whether it is its metabolism, whether it is its reproduction, whether it is producing heat, whether it is not producing heat. So every function has something to do with the thyroid. And that's why it is so ubiquitous as a disease, as ubiquitous as a disorder. And that's why it is so important for all of us. I hope that was not too long of an answer, but I thought it was a good introduction.
So wonderfully said. Essentially, the thyroid is a little butterfly-shaped gland in the neck, which produces thyroid hormone, which controls the energy levels in the body. And for our viewers, Dr. Krishna Seshadri very clearly mentioned that the symptoms of thyroid disease often are the symptoms of a life, in the sense that the thyroid gland controls the orchestra of life. There are three types of thyroid diseases. There are many types, but there are three important types. One is when the thyroid doesn't make enough hormone. That's called hypothyroidism. The second is when the thyroid gland makes too much hormone. That's called hyperthyroidism or thyrotoxicosis. And the third is when the thyroid gland has a swelling in it. That's called a goiter. And the goiter or the thyroid swelling can either be a benign swelling or it can be rarely a malignant swelling. But the important thing about thyroid diseases is that once diagnosed, thyroid diseases can be very easily treated. If the hormone levels are high, you bring down the hormone levels. If the hormone levels are low, you supplement or increase the hormone levels. And if there's a tumor of the thyroid gland, you take care of it surgically or through other means, usually surgically. And of course, there are other nuances and so many complexities of treatment, but these are the common thyroid diseases. With that, let's talk about the simple thyroid function test. Our viewers would have seen thyroid being tested in labs, and they would have seen three tests: T3, T4, and TSH. Let me request Dr. Seshadri to tell us about these three little hormones. They are not so little, but these hormones, how our viewers could try to understand the complex interplays between these hormones.
So it's very interesting because this is classic endocrinology, and learning to interpret it makes a lot of sense. So a lot of patients will come and say, "Doctor, you're telling me I have low thyroid, but my numbers are actually high." So let's take half a second to understand this. So there are two glands actually. There's a gland in your neck called the thyroid gland that makes thyroxine, T4, and T3. So these are the two players. And there's a coach that is sitting in the brain, in the bottom of the brain, right where my tilak is, right exactly behind, called the pituitary, which produces a hormone called TSH. So normally, what is happening is that think of the pituitary as a master, as the cartwright, and the thyroid as a horse. So the horse is running slow, the horseman whips it, right? So when the thyroid is low, the pituitary tries to stimulate it, whip it, and therefore the TSH, which is a hormone that is produced, thyroid stimulating hormone that is produced when the pituitary goes up. In fact, we use the TSH because it's much, much more sensitive than even the hormones that the thyroid makes. So a measurement of the T4 and the TSH gives you the relationship. When the horse is running very fast, what does the horseman do? He pulls back the stimulus. So when the T4 is elevated, the TSH becomes zero or suppressed. There is no stimulus going. So with this simple relationship, we diagnose thyroid disease. We order two tests mostly. We suspect a disease. We can just get a TSH when you're trying to screen. But when most endocrinologists, when they suspect the disease, they get two tests. One that measures the thyroid hormone, and one that measures the pituitary hormone. If the thyroid hormone is low and the pituitary hormone is high, that basically tells you that your thyroid is working less, so it's called hypothyroidism. If the thyroid hormone is high, remember the horseman pulls away the stimulus, the cartman pulls away the stimulus, the TSH becomes zero or suppressed, that's high thyroid. So just based on these relationships, we make a diagnosis. Just to add to you, and because we're both doctors and we have to survive, Remember that we don't treat the numbers, we treat the person with the disease. So the symptoms and how they present also matters because there are nuances to this.
Wonderfully said. So the most important thing is that many patients, the most common thyroid disease is hypothyroidism, which means the thyroid gland isn't producing hormone. So many patients come and ask, doctor, you said I have hypothyroidism, my gland isn't making hormones, but why is my TSH high? My TSH is actually high. So Dr. Krishna Seshadri very elegantly gave the example of the horse and the whip. And when the thyroid gland is not making enough hormone, behind the tilak area or the bindi area of the head is a little gland called pituitary, which makes TSH, which tries to make the gland work. So when the TSH is high, that means the gland is making less hormones. Conversely, when the gland is making more hormones, the TSH is low. So this is very important to remember. So let me talk about the most common cause of thyroid disease, which is hypothyroidism. And the most common causes of hypothyroidism, iodine deficiency and autoimmune thyroid disease. Iodine deficiency, luckily, with the iodization of salt in our country, iodine deficiency has become rarer, less common. But autoimmune thyroid disease, where the thyroid gland fights against the blood and the blood fights against the thyroid gland, that autoimmune disease is called autoimmune hypothyroidism, autoimmune primary hypothyroidism. It's also called Hashimoto's thyroiditis after the Japanese doctor and researcher who described it. Very interestingly, there is a form of diabetes. There are many forms of diabetes. A common form of diabetes is type 2 diabetes, but there is a form of diabetes called type 1 diabetes seen in children, which can also be autoimmune. Let me ask Dr. Seshadri to tell us about these two diseases, autoimmune thyroid disease and type 1 diabetes. How many patients have both, and how are his thoughts about these two diseases and their management?
Thanks. It's very interesting because when you look at the relationship between the thyroid and diabetes as a big picture, you're always confused whether these are just travelers in the same train of disease or are they related. But when it comes to type 1 diabetes, we know that it is related. With type 2, we can argue and we can discuss it. But with type 1, we know that it is related, that both have the same origins at some point of time, which is autoimmune, isn't it? Just to summarize autoimmune, let me quickly give again an analogy. Today is my day to give analogies. So let us say you are in a building that is a high security building, right? And you don't have an ID card. Normally, the security will send you out, even if you're an employee. But this is not. But for the body is not just a building with a security. It's a building with maximum security. There are cells that patrol the body all the time and figure out if a particular organ does or does not have an ID card. What happens to both the pancreas, the beta cells, as well as the thyroid, is at some point of time they have lost the ID card that they should have. That prevents the security guards from attacking them. Here, the security guards have only one purpose. If they don't recognize you, they kill you. And that's really what the cells of the body do. So by some mechanism, which we don't have to go into today, the pancreas, the thyroid, and many other organs in patients with type 1 diabetes lose their identity card. And the body starts producing antibodies that ultimately kill the thyroid as well as the pancreas and these other cells. And that's really what is happening. And these autoimmune diseases run together. In type 1 diabetes, this is especially very common. In fact, that is why while we treat type 1 diabetes, we also look for thyroid disease in these patients. Screen them, it's one of those few indications where the anti-TPO antibody is actually recommended. And we follow them if the thyroid tests are normal, the anti-TPO antibodies are positive, we still follow them. and many of us get periodic thyroid function tests. So this is a very, very important relationship, and one that is very, very well established. Must remember, since we are doing type 1 diabetes, remember that there are other conditions, especially in children and adolescents, where there is a high incidence of thyroid disease. That includes conditions like Turner syndrome, where one X chromosome is not present, Downs or trisomy 21. So there are many conditions in children besides type 1 diabetes where this is an important part. Pune, I hope that's enough. You can continue.
Yes, I completely agree, and I really like that analogy of the security guard and the ID card being lost, and this, like the security guard attacks an employee of the building, thinking that it's a foreign employee or not a foreign, maybe a person who's not an employee trying to enter the building or an invader. The body suddenly thinks of the thyroid gland as an outsider and starts attacking the thyroid gland. One way to find out this attack is, like Dr. Seshadri said, is to measure an anti-thyroid antibody called anti-TPO antibodies. These antibodies tell us that the body is fighting. And what is the importance of this? Sometimes when the body is fighting against the blood, against the gland, let's assume that the thyroid is fighting against the blood, and the antibody is fighting against the thyroid. Sometimes the thyroid gland wins this fight, and the thyroid gland starts making hormones. So we as doctors can start reducing the hormone tablets. Sometimes the thyroid gland loses the fight and the antibody wins. And that time the thyroid hormones start going down, and then we'll have to increase the thyroid hormone tablet dosage. So things like that are the clinical importance. And another importance of what Dr. Seshadri said is that children with type 1 diabetes, if they have a thyroid gland failure as well, because in both cases the body fights against, in type 1 diabetes, some of the cases of type 1 diabetes, the body fights against the cells called the beta cells in a gland called the pancreas. The beta cells job is to make insulin, and when this fight is on, the insulin isn't produced and diabetes happens. Similarly, the same tendency is reflected in the thyroid, where the body fights against the thyroid, and this thyroid gland is not able to make hormones because it is damaged by the fight. In children, type 1 diabetes usually happens in youngsters and in children. When they have thyroid disease, it affects their height, their learning ability in school, academic performance, and it interferes with their puberty. So, therefore, in children with type 1 diabetes, up to 25% of them can have thyroid gland failure or hypothyroidism, and therefore, once a year, they need to undergo thyroid function test. Now, let me go on to a little more contentious topic, which has a little bit of controversy. In type 2 diabetes, which is a common form of diabetes in the world, in fact, it is associated with obesity, high cholesterol, hypertension, and interestingly, thyroid gland failure is also associated with weight gain, high cholesterol, etc. So, may I ask Dr. Seshadri to comment on, in type 2 diabetes, if somebody has hypothyroidism, how does that impact problems such as and weight and cholesterol levels, so on and so forth?
Thank you, Uni. So really, I like the way you expanded on the type 1, and this has been controversial for a long period of time. First thing is, is a lot of times, as we started out, a lot of symptoms that we have are the symptoms of life, and they are also symptoms of thyroid disease. Diabetic patients, being obese and others, will, if you do 14 tests, generally you'll find one of them abnormal. So the question is a mild TSH elevation. We know that if the thyroid is really low, if the TSH is more than 10, right, then there is some correlation. But a lot of times what happens is that somebody would have gotten a test as part of a master health checkup or as part of an annual screen, or if they go to a lab, they would be told, this extra test is thrown in for you free, and you will find a TSH that is mildly elevated. So the question is that if you treat that, first, should you treat that? Second is, if you treat that, will it bring down your weight or your cholesterol? The bad news is it is probably, the more your weight is, the more likely that your TSH is a little elevated, right? So we know that let us say your body mass index, which is your weight divided by height in meters square, is what we as endocrinologists use to measure obesity. So as your BMI increases, it's very likely that if you measure a TSH, it is a little high. And treating it or bringing it down is not probably going to change your weight much. This is the first bit. The second bit is that we have looked at this very carefully, and Uni and I are part of the group that developed the guidelines for the RSSDI that's just published this month. I think, the TSH may not be related to type 2 diabetes, but it's often found running with each other. But some there is a common soil there. That is that when you have more risk factors and more comorbidities with diabetes, the chance that you can have thyroid dysfunction is also higher. Many of the societies think that you must look for thyroid disease if you have diabetes after a certain age, right? Not with great evidence. But many of us probably feel that if you have a lot of comorbidities, let us say you are a diabetic and you have eye disease, you're a diabetic and you have eye disease and kidney disease, you're a diabetic and you have eye disease, kidney disease, and heart disease, then you're probably somebody that we should look for thyroid dysfunction. And if it is present, to treat. Having said this, I would recommend that before you start getting thyroid function tests, talk to your doctor if you need it. A lot of time, a TSH that is 4, 5, or 6 is only a mental worry and not a physical problem. That you're going to live with that TSH in your mind rather than in your heart or your blood or your kidneys. So more than the test, I think a good clinician who knows you, who works with you, is the right person to help you make a decision whether you need the thyroid function test. I hope that sort of covered some of the stuff, and you can add it in your own amicable way.
Thank you. That was very well explained, and I'd like to add that when the TSH, as I said, is high, the TSH comes from the pituitary, and the body's TSH increases and it tries to make the thyroid gland work. So when the thyroid gland doesn't work, the body pituitary gland in the brain increases TSH. So the TSH, the normal TSH is somewhere between 0.4 to 4, very roughly. So if the TSH is above 4, that means the thyroid gland isn't working very well. But when the TSH is above 4 and when the thyroid gland producing, the hormones produced by the thyroid glands such as T4 are normal, then we call it as mild hypothyroidism. We call it subclinical hypothyroidism. Now, many patients, or rather most patients with subclinical hypothyroidism, like Dr. Seshadri mentioned, they do not require treatment. Only if the TSH is very high, more than 10, or if they have comorbidities such as high cholesterol levels, they will require treatment. And of course, if they are pregnant or if they are planning pregnancy, that's when we treat even subclinical hypothyroidism cases. But otherwise, many cases of subclinical hypothyroidism or mild hypothyroidism need not be treated. Some of them may even spontaneously remit. And the point which Dr. Seshadri said, going and doing a thyroid blood test is very important, because once you do a test, you're going to get an abnormal result, and not everybody requires treatment. In fact, many people with mild, subtle abnormalities in thyroid function do not require treatment, and it's important to see a doctor who's well versed with thyroid management, because in many endocrine diseases, including the thyroid, it's important to know when not to treat rather than to know when to treat. So that is an important distinction, and many patients do not require treatment. Of course, severe cases require treatment, and like Dr. Seshadri said, many people say that, doctor, my thyroid function is a little bit abnormal and I'm putting on weight. My TSH is high, which means my thyroid hormone level is low, I'm putting on weight. Do you think I require hormone? The answer, like Dr. Seshadri said, is no, because mild degree of hypothyroidism may not treating that may not improve the weight at all. It, in fact, severe hypothyroidism itself only changes the weight by a kilo or two. Uh, so do not expect that thyroid is a cause of very severe obesity, and obesity and type 2 diabetes can improve with weight reduction, lifestyle measures. Of course, medicines are also there, but in general, thyroid hypothyroidism treatment does not improve the body weight. Let me ask Dr. Seshadri before we conclude another question. Uh, Supposing somebody has got a thyroid nodule, uh, how do we know that it is a benign nodule? Can you tell the viewers the common test that we as doctors do so that they don't have to worry about a thyroid swelling? Sometimes they have a swelling in the neck, sometimes they have a swelling in the side of the neck, and they worry. Sometimes it's not even the thyroid gland. Could you simply illustrate for us the thyroid nodule or the goiter, as we endocrinologists call it?
So I have the first thing is to learn before you hit panic buttons. Learn to know if it's a thyroid swelling. So a simple test that you can do home is a mirror and a glass of water. Take the mirror, see how pretty you are, and then take the glass of water, put it into your mouth, then look at the mirror and swallow. If that swelling moves up with the mirror, then it's a thyroid swelling. So I think that's one thing to remember. So that tells you it's a thyroid swelling. Your doctor will take a history and figure out whether that is a high risk. For example, if it is not moving, if you have a family history, if you're a male, all of these sort of indicate that it is a high risk. Most people who have these swellings are women, and if I do an ultrasound on 100 people, 40 to 60% may have a small swelling. So don't panic. Today, a good ultrasound done by someone who's capable of reading it correctly and giving a report that gives you a score called the thyroid score is almost always the only test that is required in the majority of people. So, a good ultrasound is a test that I do. And then, if it is a score that is less than 3, which is a thyroid 2, I don't even go to the next step. The next step is to take some tissue. When I was a student, they used to say when tumor is a tumor, tissue is the issue. No longer. We have exceptional ultrasounds. And then if it is more than 3 or 3 or more, then the doctor will do what is called a fine needle aspiration cytology. And that's really all that's required. The majority of people will not have a malignancy. If it's a malignancy, then you would require surgery. But most of us, including Dr. Unnikrishnan and I, we play the long waiting game in endocrinology. The greatest prescription in the endocrinologist armamentarium is patients and clinical follow-up. We just watch it, we check it periodically. If it grows, then we may consider another FNAC. The majority of the patients, we just reassure and watch. We don't let it go. We watch. That's all that we do for most nodules. But a few of them can be cancer, and they require aggressive, appropriate treatment.
I think that was wonderfully said. If somebody has a swelling in the neck, the first thing to do is, of course, go to the doctor, get it examined, and then the doctor will probably order some blood tests and the ultrasound. The ultrasound, as Dr. Seshadri said, is very critical. There are certain simple scoring systems which will tell the risk. Where required, the doctor may ask for a needle aspiration, where they put a needle into the nodule critical area and take a little bit of fluid, look at it under the microscope. These are the only tests that will be done. Now, if results are benign, then absolutely, like Dr. Seshadri said, wait and watch. If there is a suspicion of malignancy or a malignancy, like Dr. Seshadri said, which is very rare to get thyroid cancer, we ask the patient to undergo surgery. But remember, thyroid cancer is, once diagnosed, is very easily treated by surgery, and very good cure rates with early surgery are there, and therefore there's no need to panic. So in conclusion, before I hand the mic over to Dr. Seshadri and to Dr. Purvi, I'd like to say that thyroid diseases are three mainly. One, the thyroid gland not producing hormone, hypothyroidism. gland producing too much hormone, hyperthyroidism, swellings of the thyroid gland. Once diagnosed early, they are very simple to treat. The hormone levels are low, increase the hormone levels. Hormone levels are high, reduce the hormone levels. If there's a thyroid nodule, if it's benign, just wait and watch. If it is malignant or likely to be malignant, surgery, and surgery has excellent results. Now, I'd like to request Dr. Seshadri for his final thoughts on this interplay between diabetes and thyroid disease in this program by the Research Society for the Study of Diabetes in India.
So thank you. Me, it's like just the two of us. They go together, and they go well together. So just the two of us. So and they can affect each other, and taking care of one may probably help the other. But there are lots of enigmas, just like the two of us. So that's exactly it. And we are learning so much more about the thyroid and diabetes. A few years ago, if somebody would say type 2 diabetes and thyroid, I would say, you're wasting my time. But today, I'm seeing things to say, okay, maybe the comorbidities have an indication. But as in everywhere, watch this space, because we keep learning more, and I think that is the big part of it. So and interestingly, to close this up, there are many congeners of thyroid hormone that are waiting in the wings to become diabetic drugs and obesity drugs, work on brown adipose tissue, on mitochondrial metabolism. So what we've learned in the last 200 years is probably not a tenth of what we're going to learn and do in the next 10 years. So maybe a couple of years down the line, Purvi will have us talk about those together. And as usual, it's been so wonderful being with me. We know each other for many years, and I've learned so much from you. Thank you so much.
Thank you. Wonderful to be with you, Dr. Seshadri. So nice and to be with you, and also the team from the organizing team led by Dr. Purvi and Dr. Farishta. Over to both of you.
Thank you so much. You both lightened up the screen completely. And thank you for covering the basics, right from what the thyroid gland is, the function, all the way to, the autoimmune nature of it sometimes, the types of clinical manifestations, the tests for screening and for follow-up, and then the interplay with diabetes, the weight management issues along with it, and then tests to even rule out cancer, thyroid cancer. So thank you for covering that entire gamut in such a short span of time. And we know, and RSSDI appreciates the fact that you both are extremely busy endocrinologists with great clinical practice and also research attributes. And we thank you for taking the effort and being there for Diabetes Bytes today. A very big thank you from Dr. Vasant Kumar, Dr. Sanjay Agrawal, and the entire EC, as well as the RSSDI social media cell. So thank you again for being there.
Yeah.
Thank you, Dr. Purvi. Thank you, Dr. Farishta. And thank you, sir, Dr. Krishna Seshadri. It's been an honor to be with you as always.
Thank you, everyone.
Yeah, thank you so much. Thank you so much, sir, for taking our time.